Welcome, everybody. Thank you for joining us today. My name is Adam Kalinowski, and I'm the president of Dystonia Europe. Dystonia Europe is a pan-European umbrella organization for national dystonia associations. This year, we had to cancel our annual conference and other face-to-face meetings. That's why we decided to lead a series of 10 webinars to give you the opportunity to learn more about dystonia-related topics and ask questions to specialists. And today is the second webinar in this series. Before I give the floor to Monica, I will who will introduce you to today's webinar and our guests. I want to let you know that you can ask questions to our specialists during the meeting. You can ask your questions using the chat option, and our chair specialist will follow the questions and ask them to after the presentation to our speaker. Thank you and enjoy our webinar. Monica?
Thank you, Adam, and hello, everybody. It's very nice to be here this afternoon for this webinar, our second webinar in this Dystonia webinar series. And today we have two panelists who are both on our Dystonia Europe Medical Advisory Board. And the topic today is dystonia and mental health and living well with dystonia. And it will be presented by Professor Emeritus Marjan Jahanshahi, clinical psychologist and neuropsychologist at the Queen's Square Institute of Neurology in London. So welcome, Professor Jahanshahi.
Thank you.
And you have presented at many of our face-to-face meetings for patients in the past. And being a dystonia patient myself, I have always felt, and I always feel when I listen to you, that I am reminded of things and I learn new things about how to manage and cope with my dystonia. So it's exciting to have you here and to have your knowledge and expertise and your advice on living well with dystonia to share with this audience. And then I also would like to say welcome to our other panelist, Dr. Francesca Morgante, a consultant neurologist and specialized in movement disorders at the St. George's Hospital in London. So welcome to you. And Francesca will keep track of all the questions. And please submit the questions in the chat box, like Adam explained. And I now wish you a very interesting webinar. And I give the word to Francesca.
Thank you, Monica. Thank you, Adam. I'm extremely honored to chair this session organized by Dystonia Europe. And let me thank Dystonia Europe for their engagement and what they do for all people with dystonia. And I'm just reminding you to type your question on the chat box. I will track them and I will answer. I will ask them to Professor Jahanshahi later on after the handover talk. And now I will pass on Professor Jahanshahi for her talk on mental health and dystonia, living well with dystonia.
First of all, let me thank Monica and Adam for inviting me to give this webinar. It's always a pleasure to be back with my friends at Dystonia Europe. And I would also like to thank Francesca for agreeing to moderate the questions. So I've been asked to talk about dystonia and mental health, living well with dystonia. Today, I apologize that I am not wearing a jacket or a suit, but it's 32 degrees in London and it's extremely hot. And I had a t-shirt and trousers on this morning, but my daughter convinced me that I should consider it a special occasion and put a dress on. So I'm sitting here talking to you in a pink dress. You may be able to see some of it. So this is the content of my talk. I'm going to first talk about mental health and dystonia, and then talk about self-management, what you can do as somebody who has dystonia to cope and live well with dystonia. And I have focused the self-management approach to living well during these unusual times of the pandemic. So first, mental health in dystonia. Now, I put in this busy slide to just show you that there's a lot of research on mental health in dystonia, including some of our own studies here. And this is only in 2011, and there are even more studies since then. But I've summarized the key points from the previous slide and all those studies here. The most important mental health issues in dystonia are depression and anxiety. Depression, so feeling sad, feeling tearful, feeling lacking satisfaction in life, is experienced between 19 to 47% of people who have dystonia. This is quite a high rate when you consider it against the rate of 4.3% that the World Health Organization considers for the global rate of depression across the world. So depression is one of the mental health problems experienced by about a quarter to half of people who have dystonia. The other group of disorders are anxiety disorders. I will talk about management of anxiety later on. And these anxiety disorders, feeling tense, feeling having a sense of dread, having a sense of threat, being tense is experienced by about 25 to 69% of people with dystonia. And again, when you consider this against the rates of anxiety in the general population, which is about 3.6%, these are relatively high rates. So depression and anxiety as relatively common mental problems in dystonia. But even these figures suggest that there are about 30% of people with dystonia who don't have these mental health problems. So while a proportion of people who are affected by these problems, about 30% don't experience these mental health problems. The other common mental health problem that has been associated with dystonia is obsessive compulsive disorder, which is a form of anxiety disorder. This is having obsessions or repetitive ruminating thoughts or compulsions, which are repetitive behaviors such as compulsively washing your hands or compulsively checking the gas and the front door, etc., to the extent that these become disruptive of your daily life activities, is another mental health problem associated with dystonia. There's some disagreement about the rate of obsessive compulsive disorder in dystonia, depending on the exact type of measurement that is used, but the probable rate is about 20% of people with dystonia experience some form of obsessive compulsive disorder. Now, to give you an idea of the scale of the problem, this slide from a study in Germany of 116 people with spasmodic torticollis or cervical dystonia, as it's known now, were compared to a general population sample from the German general population. And as you can see, the lifetime rate of the mood disorders, so depression, anxiety disorders, and social phobia is quite high, 50%, 70%, 83%. Social phobia is a fear and anxiety about interacting with other people. And when you look at the current rates of these problems, compared to the German general population, the scale of the problem becomes clear. Current problems means experiencing these mental health problems within the past 4 weeks. So mood disorders were twice more common in dystonia than the German population. Anxiety disorders were 6 times more common in people with dystonia than the general German population. And social phobia was 10 times more common in people with cervical dystonia than those of the general population in Germany. So this gives you an idea of the scale of these mood and anxiety disorders, and specifically social phobia, or the fear of interacting with other people. Now, this study from America looked at the association of mental health problems, mainly depressive disorders, with presence of the DYT1 gene, which is a common gene found in people with dystonia, and compared people with dystonia who had DYT1 gene, so manifesting carriers of the DYT1 gene, as they're called, and compared them to people who had the gene, who had the DYT1 gene, but didn't have dystonia symptoms. So these were non-manifesting carriers of the gene, and then compared this group with non-carriers of the gene, so people who didn't have the gene at all. And what they found was that certain types of depression, recurrent major depression, the risk of it was significantly higher in the dystonia patients with DYT1 gene, as well as the non-manifesting carriers of the gene compared to the non-carriers. So the take-home message from this study is that presence of this recurrent major depression is associated with presence of the DYT1 gene, regardless of whether you have dystonia symptoms or not. So the important factor is presence of the DYT1 gene, which makes you more vulnerable to developing recurrent major depression. Another common problem, mental health problem in dystonia, is with sleep. Although dystonia tends to improve when people sleep, but in general, people report that the efficiency of their sleep, the quality of sleep, is affected. About 70% of people with blepharospasm and 70% of people with cervical dystonia report this, and it takes them longer to fall asleep. So latency of the sleep, the onset of the sleep is delayed, and the sleep is disrupted by many arousals. So when people have recorded the EEG during sleep, it's called polysomnography, they have found that the EEG during sleep is not abnormal, but the amount of REM sleep, this is rapid eye movement sleep, this is the type of sleep during which we dream, is reduced in people with dystonia. The other thing is that they have, some studies have not found a correlation between severity of dystonia and sleep problems. Some studies have found correlations between the presence of depression and sleep problems, but even when you control for presence of depression, the sleep problems in dystonia still persist, and suggesting that perhaps these sleep problems in dystonia are part and parcel of the same biological process that gives rise to the dystonia, so that they are primary. Another common problem, a mental health problem in dystonia, is pain. For people who've got cervical dystonia, the presenting symptom, so the first symptom with which people go to the doctor is pain in about 10% of people. And pain experience for people who have got cervical dystonia is very common. 66% to 90% report some element of pain in their necks. And other forms of dystonia, such as people with blepharospasm, people with writer's cramp, also report experiencing pain. So pain, again, another common mental health problem. One of the questions that has been interest to researchers and also may have implications for the clinical management of these mental health problems is whether these mental health problems in dystonia are primary or are they secondary. If they're primary, they would be part and parcel of the same biological, chemical process that gives rise to dystonia. If these mental health problems are secondary to dystonia, then they would be considered to be a reaction to living with this chronic condition. And on this slide, I've summarized evidence for both. So in support of the primary etiology of these mental health problems, there's evidence suggesting that there are high rates of depression and anxiety in about 34 to 40% of people before the onset of the movement disorder. So before people get dystonia, the 34% to 40% would have been depressed or anxious before the dystonia developed, which is suggestive of a primary route of causation. The other thing, as I showed you in the case of the Hyman study, is that certain types of depression are higher and with earlier age of onset in association with presence of the DYT1 gene in both manifesting and non-manifesting carriers of the gene. So people who have dystonia and people who have the gene but don't have dystonia. So these all suggest that maybe these mental health problems are associated with the primary causal route. In support of the secondary nature of these mental health problems, there is evidence from our own work and others suggesting that depression and anxiety are associated with the severity of dystonia. So the more severe your dystonia is, the more likely you are to experience depression and anxiety. And many, many years ago now, as part of my PhD in collaboration with the late David Marsden, we did a longitudinal, a follow-up study of people with cervical, 100 people with cervical dystonia over a 2-year period. And we found that the changes in depression and disability very closely reflected the changes in severity of cervical dystonia. So if the cervical dystonia got better, depression and anxiety got better. If the cervical dystonia got worse, the depression and disability got worse. And there is lots of evidence suggesting that when you treat dystonia effectively, either with botulinum toxin injections or with deep brain stimulation surgery, then depression and anxiety also improve, suggesting that these problems may be secondary. In my own opinion, this sort of black and white thinking between primary and secondary is an oversimplification. Probably both are true, that some of these mental health problems are primary and other aspects of these mental health problems in dystonia are a reaction to living with this chronic illness. Now, another important factor in dystonia is the fact that in some forms of dystonia, the involuntary postures and movements give people a sense of disfigurement, and these are visible to other people. For example, in generalized dystonia, in cervical dystonia, or in blepharospasm, or in mesh syndrome. And this disfigurement, I believe, is one of the hidden symptoms of, if you like, visible but non-appreciated symptoms of dystonia, which has got implications for mental health. And many years ago, I tried to tease out the effects of this postural abnormality and disfigurement on depression in cervical dystonia, and we studied 100 patients with torticollis or cervical dystonia and compared them with about 40 patients who had cervical spondylosis. This is sort of arthritis of the neck. So they have stiffness of the neck and pain, but they don't have the postural deviation or the postural abnormality. And when we look at the features of depression in these two groups, we found that the people with cervical dystonia had significantly more, more of them were depressed, compared twice as many almost than the people with arthritis of the neck. And interestingly, when we look at the features of depression on the Beck Depression Inventory that distinguish the two groups, the people with cervical dystonia reported elements of depression such as lack of satisfaction, sense of punishment, self-blame, self-accusation, self-punitive suicidal thoughts, and most importantly, a negative body image. So this resulting from the postural abnormality of the head was endorsed by 39% of the people with cervical dystonia, compared to about 4% of the people with cervical spondylosis. So suggesting that this disfigurement may be a core element of depression in people with cervical dystonia. And then in a later study that we did with Laura Lewis and Ginger Butler on a large sample of patients with all forms of dystonia, not just cervical dystonia, but also focal, segmental, generalized dystonia, we found a similar thing, that although the somatic aspects of depression were present, things like inability to work, or fatigability, or loss of libido, etc., but the affective symptoms of depression were also present, highly endorsed. You can see the last column, but again, being critical of one's appearance. On item 14 on the Beck Depression Inventory was endorsed by 50% of people with all these forms of dystonia, again suggesting that this negative body image, negative body concept resulting from the disfigurement was an important element, an important feature of depression. And this was further supported by some of the studies that we did looking at predictors, well, the factors that predicted depression in cervical dystonia and then in all forms of dystonia. And again, we found that disfigurement and body concept, the body image, negative views about body image were predictors of depression, not only in cervical dystonia, but also in all forms of dystonia. The other thing that is probably important and again maybe under-investigated is people with dystonia's perceptions of stigma. Stigma relates to being perceived as being different by other people, being avoided by others, or avoiding other people, being self-conscious. These are the items from the stigma scale. And as part of his PhD, Ilias Papatanasiou actually looked at perceived stigma in people with cervical dystonia and also people with spasmodic dysphonia. And if you look at the last columns, which is not visible for the cervical dystonia group, but a large proportion of the people with dystonia, ranging from 45% to more than 90%, report elements of perception of stigma as a result of the visible nature of their dystonia. Now, on the basis of these results, I've developed a reactive model of depression and social disability in cervical dystonia, according to which cervical dystonia or even generalized dystonia give rise to visible abnormal postures and movements, which results in a sense of disfigurement, which on the one hand causes a negative body image or a negative body concept, so negative evaluation of feelings towards the body, and which in turn contributes to low self-esteem, and low self-esteem results in depression, a well-known consideration and the association between low self-esteem and depression. And on the other hand, this sense of disfigurement is associated with perceived stigma, results in social embarrassment, and in turn results in social avoidance, which can result in social isolation of people with dystonia. That has been looked at now in great detail is quality of life in dystonia. This is a person's sense of well-being and their ability to fulfill their major roles in life, such as self-care, mobility, occupying time, economic independence. And with Donna Page and Ginger Butler, we looked at, you use the Eurocall, which is a generic measure of quality of life, and found that compared to data from the general population, people with dystonia had impairment in usual activities and in pain and in anxiety and depression, and but weren't so affected in self-care and mobility. But again, this, together with lots of other evidence, suggests that dystonia can have a negative impact on many aspects of quality of daily life and quality of life. As a result of the pain and the disability, employment rates in dystonia are relatively low. Between 30% to 50% of people are still in employment, and pain is a major cause of disability, resulting in people giving up their jobs. And the evidence from a study in Norway suggests that being younger and having higher levels of education makes it more likely that people with dystonia remain in employment. And similarly, people who have successful treatment of their dystonia with botulinum toxin injections tend to remain in employment or resume employment. So let me very briefly summarize what I've told you so far. So depression, anxiety, and obsessive compulsive disorder are the common mental health problems in dystonia. Sleep is affected. Pain is a common experience. Dystonia affects people's ability to work, and many people with dystonia are employed. People with dystonia perceive high levels of stigma, and the sense of disfigurement and negative body concept are features of visible forms of dystonia, which contribute to this sense of depression and low self-esteem. And dystonia has a negative impact on quality of life. At this point, I feel extremely guilty because I feel that I've given you a negative view of things about mental health issues in dystonia. But there are two positive messages that I can add here. One is, as I said in the beginning, about 30% of people with dystonia manage to protect themselves against mental health problems. So they don't experience depression, anxiety, or OCD. So this is good news. 1/3 of people with dystonia don't have any mental health problems. The second good news is that when dystonia is successfully, I've tried to summarize medical management of these mental health problems here in one slide. When dystonia is successfully treated with either botulinum toxin injections or with anticholinergics or with deep brain stimulation surgery, then this improves depression and disability as well as quality of life of the patients. And I think in previous presentations that I've given to Dystonia Europe, I've presented the evidence for this. And but despite this good news that successful medical treatment improves the mental health problems, there are some cases that despite having successful treatment of their dystonia, for them depression and anxiety may persist. And in these cases, it's important to treat for neurologists to treat the depression and anxiety directly by either using some form of medication, antidepressant medication or anti-anxiety medication, or by referring people for cognitive behavior therapy, which is evidence-based, and there is a lot of good evidence that is very helpful in overcoming depression and anxiety. So that's the other second good news. Now, to move on to the second part of my talk, self-management strategies for living well with dystonia. Now, much of medicine is dominated by the medical model of health. According to this medical model of health, doctors are seen as rescuers of patients from their illnesses. A self-management model is very different. In this model, doctors help patients to manage their disorders. So it's a joint partnership between doctors and patients in managing their problems. And this self-management approach is increasingly advocated because it empowers people to get involved in the management of their chronic disorders. So the self-management in dystonia really is talking about things that you can do to live better with dystonia. And Adam has defined self-management as the task that an individual has to undertake to live well with the chronic condition. And these tasks include medical management, so which treatment to have for your dystonia, role management, the impact of dystonia and its medical treatment on your ability to fulfill daily roles, looking after children or going to work, etc., and emotional management, the impact of the dystonia and its treatment on your mental health. So in the past, I've presented you with these strategies for living well with dystonia, which for the lack of a better term, I've called the 23 commandments. And although a lot of them are common sense strategies, they're all based on evidence from either clinical psychology or from positive psychology that they work in helping people live well with under challenging conditions of a chronic illness, such as dystonia. But today, instead of talking about these 23 commandments, I thought, since we're all living with a new challenge, the COVID-19 pandemic, I will focus on talking about 10 strategies that I think would be helpful for all of us for living well with dystonia during the pandemic. And again, the strategies that I'm going to talk about are based on evidence from clinical psychology or positive psychology that show that they work, that they help people feel better. So the first strategy would be to establish a daily routine. These are unusual times we're living through, and it's important to establish a daily routine so that you develop a sense of a normal life. So on a daily basis, engaging in activities such as self-care, working, cooking and eating, exercising, connecting with other people, having some leisure activities. These all work to give you a sense of a pattern of normality to your life, despite the restrictions that have been imposed on all of us during the pandemic and during the lockdown that many of the European countries have endured. The other thing is to set goals and aim to achieve them. There's evidence suggesting that we all feel better when we have a purpose, when we have a goal. A purpose and meaning makes us feel better and increases our well-being. And these goals can be SMART goals, things that are specific, measurable, attainable, relevant, and time-bound. They don't have to be anything elaborate. Setting yourself the goal of completing a piece of work and forwarding it to your employer, or dealing with the backlog of your emails, or painting the kitchen wall can all be goals that can be achieved in a day or a couple of days, and rewarding yourself for doing so. The other thing that is important during the pandemic is to, although we've all been trying to listen to the news, to follow instructions from our governments about what to do and what not to do, you know, the hand washing and the social distancing, it's important not to track the news obsessively, because overdosing on the news, especially in the early parts of the lockdown when there were so many people in the UK, for example, who were dying, was really upsetting and depressing. Aiming for mental and physical well-being despite the restrictions on our daily lives are important. Sleep is very important for our overall well-being. So is eating a balanced diet, and exercising for stamina, for strength, for endurance is equally important. Keeping yourself mentally and socially engaged, developing your sense of curiosity and learning new things are another way of establishing or fitting it into your daily routine. Now, when we're faced with any form of stress or challenge, sometimes the easy and short-term option is to resort to tranquilizing ourselves with either drinking too much, or overeating, or using mental strategies such as distancing or wishful thinking or worrying or running away from your problems. These are all maladaptive strategies. They're maladaptive because they don't help you improve your adjustment to this situation, which is the challenge of living with the pandemic. And instead of using these maladaptive strategies, you could improve your adjustment to the circumstances of the pandemic by finding forms of entertainment, such as listening to music, watching movies, reading, anything that gives you pleasure, but also distracts you from the stresses and the anxiety of the pandemic. Reaching out and connecting with your friends and family it helps in both sharing your news, as well as reducing their sense of isolation, as well as reducing your sense of isolation when you connect up through Zoom or FaceTime. Using the time that is afforded to you by the pandemic to sort out things that you've been putting off for a while, like cleaning up your cellar, your attic, or backlog of work that you have been trying to deal with. And as I said, learning new skills, such as a new language, or how to crochet, or how to solve puzzles is another option. The pandemic certainly has created a lot of worry for most people about their own safety, as well as the safety of their friends and family. And worrying means being preoccupied with thoughts that you revisit over and over again without them being helpful in any way. And this worry tree that I've taken from Bupa, the private health provider in the UK, I found useful because it makes a distinction between two types of worry: practical worries and then what if or hypothetical worries. So if you start off by asking yourself, what are you worrying about? And then you ask yourself, is there something I can do about it? Then if there is something that you can do about it, that's a practical worry. So for example, if you've been worrying about how to get your groceries during the pandemic, you sit down and think of your options. Shall I order them online? Shall I put my mask and gloves on and go to the grocery store and get my groceries? Shall I take up my neighbor's offer to get the groceries for me? So you consider all the options, choose the best one and go for it, and then let go of this practical worry over. What if or hypothetical worries are more difficult to deal with. So most of us have had this what if or the hypothetical worry. What if I get the COVID? What if I catch coronavirus? These types of worries, these hypothetical worries, tend to be vague and non-specific. And when you face these what if or hypothetical worries, it's important to, when you notice that these types of worries are spiraling in your head, it's important to bring yourself back to the present moment and be present in the moment, and not let your mind wander off into the future and what may happen in the future. Using some form of relaxation exercise, such as controlled breathing, can also help with this type of hypothetical worry. You could also postpone the worry. So when the worry starts niggling in your head, say, okay, I will stop worrying now, and I will put aside some time after lunch to 10 minutes to sit down and go over this worry, and even write down what is worrying me. And this act of writing down sometimes can help you let go of the worry so that it's no longer in your head. The other strategies for stopping this type of worrying is to accept uncertainty. There are lots of things that we face in life that are uncertain. The pandemic is certainly one of them. And not everything in life is controllable. Not everything is predictable. And accepting this uncertainty will help you stop worrying. And finally, about stopping worrying, learn from your experience. If you've had these hypothetical or what if worries in the past, and nothing happened, these worries didn't materialize, learn from these experience and let go. Don't develop these what if or hypothetical worries in the future. Now, another feeling that has been quite, another emotion that has been very quite common during the pandemic has been anxiety. Most of us have been anxious about our own safety and the safety of our family and friends. And then anxiety is a negative emotion that relates to perceiving some form of threat, some form of danger. And anxiety tends to be future focused. So we dread something happening to us or to our loved ones in the future. Anxiety is usually experienced when people overestimate a threat or a danger and underestimate their own ability to cope with it. So this imbalance between danger and ability to cope is what gives rise to this sense of anxiety. And anxiety has several components. It's got mental, emotional, physical, and behavioral features. So the mental element of anxiety is that sense of dread and threat that is triggered in your head. The emotional element of it is this fear and anxiety and panic that you experience. The physical symptoms of anxiety would be the butterflies in the stomach, the sweatiness of the fast breathing, the palpitating heart that you experience when you're anxious. And the behavioral features is that people who are anxious want to either escape the situation or they want to get out of the situation, escape, or they want to avoid similar situations in the future. Now, there are many strategies that can be used for overcoming anxiety. There are mental strategies for dealing the mental component of anxiety, such as distraction. One of the best ways of distracting yourself from your anxiety is social interaction. You can't be meaningfully interacting with other people while at the same time feeling anxious. So when interacting with other people, usually you're distracted away from your anxiety. The other is thought challenging, trying to identify all the biases in thinking that give rise to this overestimation of the sense of threat and the dread. Are you overgeneralizing? Are you engaging in black and white thinking? Are you discarding the positive? So these are all biases in thinking and challenging your thoughts when that sense of threat or dread starts emerging. The physical aspects of anxiety can be dealt with by relaxation through controlled breathing or through progressive muscular relaxation, and the behavioral aspects can be dealt with through graded exposure, which is a sort of dealing with what you are anxious about in a step-by-step fashion. So, for example, somebody who has public speaking anxiety, in the first step, doing public speaking in front of friends, then doing public speaking in front of colleagues, and then moving on in a graded step-by-step fashion to a public speaking in front of a larger audience. The other strategy that is helpful is to live mindfully. So a lot of us tend to operate on automatic pilot. We're creatures of habit, And a large proportion of our behaviors tend to be habitual and automatic rather than goal-directed and mindful. And mindfulness is nothing but paying attention in the present moment without judgment. And to live mindfully is stopping and noticing things, the singing of the birds, the fact that the sun is shining, or that children are playing and laughing. And there is evidence suggesting that 4 weeks of mindfulness training can help prevent relapse in people who are depressed. And mindfulness training is nothing but focusing your attention on your breathing. And when you notice that your attention is wandering off, bringing your attention back to your breathing. The next thing that is important in terms of dealing with the pandemic is perhaps building up resilience. Living with the pandemic has been challenging at times, and resilience, it comes from the word resilio, which means to jump back, and resilience is the ability to bounce back after an adversity, to fall and get up and start again, which is reflected in this quote from Samuel Beckett, the Irish playwright: "Ever tried, ever failed, no matter, try again, fail better." And resilience is a skill that can be developed, that can be built up. And there are 5 factors that are important for developing resilience. Inner drive, which is having the motivation, the self-belief, the sense of agency, and the sense of self-efficacy to say, I can solve this problem, I can take on this challenge. Flexible thinking, which is having an open mindset and trying different solutions to solve a problem, trying a new approach when the old one fails. Future focus is having a plan and having a plan and a sense of direction and purpose that prevents you from getting stuck in a situation. Strong relations, having nurturing and building up your social connections with friends and family is very important, because it allows, provides with practical and emotional support for you at difficult times. And you can always ask for help from your social support network. And energy, building up and sustaining your energy through sleep and exercise and diet, so that you can face challenges, is also important. So resilience is a skill. Resilience is something that can be developed and learned. Maintaining a positive outlook and keeping hope alive are the other 2 things that are important in these challenging times of the pandemic. It's important to banish your negative thoughts and say to yourself that these thoughts are just verbal statements that you've made to yourself. Thoughts are nothing but that. Negative thoughts should not control you or your behavior. They're not valid, they're not true. Replace them with more positive statements. Try to think of all the positive times that you've had with your friends and family, and be hopeful that you will recreate this in the future. We all have a time machine in our heads. We can go back in time and remember our memories of good times, and we can travel forward in time to the future and plan enjoyable activities. So at this time that during the pandemic, when actual traveling may be difficult, time travel in your head can take you to many exotic destinations. Keeping hope alive is important. Remember that any challenge is not forever, is not permanent. It will not last forever. This will also end, and be hopeful that the pandemic will pass. Now, at this time, with the pandemic, we're all feeling a bit vulnerable. So it's important for us to focus on and be grateful for the positive things in our lives. And remind ourselves to be grateful for all the parts of our bodies or all our organs that are working, to be grateful for our friends, to be grateful for our family, to be grateful for the ability to sit in the sun and feel the sun on our skin. And every day may not be good, but there is something good in every day if you think about it. And a very good exercise in gratitude is when you're in bed, last thing before falling asleep, try to remind yourself of three things that you're grateful for that particular day. The other aspect of positive behavior that we can all adopt and make us feel better is kindness. When was the last time that you made a cup of tea for a colleague? Or when is the last time that you gave a hug to your partner? When is the last time that you decided your family and your children needed treat and treated them with something? So engaging in daily random acts of kindness is important. Kindness is free to give, but is priceless to receive. And there is evidence suggesting that kindness not only makes the recipient of the kind act feel better, but also the person who's being kind also feels better. So engaging in random acts of kindness is free and is something that will help you feel better at the time of this pandemic and unusual times. So we've seen many acts of kindness during this period of the pandemic. All the people who have selflessly offered to get the medicine and the grocery for the medically vulnerable people, all the people who have used, volunteers who've used the phone to ring elderly people who've been isolated in their homes to reduce their sense of isolation. Or you may have heard of this 100-year-old Major Tom in the UK, who prior to his 100th birthday, he used a walker to walk the length of his garden 100 times, and he raised 31 million pounds for the National Health Service in the UK. These are all acts of kindness that help not only the people who receive the kindness, but also the people who engage in them feel better. Now, I've hinted at this importance of social support at many points, and maintaining and enhancing this your social support networks with family and friends at times of stress acts as a sort of a buffer, as a sort of a protection against the effects of stress. So important to connect up with people, share memories, have a laugh. Laughter is very useful because it reduces tension in the mind and the body, and it will help you adjust better. So these were my 10 strategies for living well with dystonia during the pandemic. And again, I haven't told you anything magical or mystical. What I've told you is evidence-based. Evidence shows that these strategies help people. So it's I leave it to you to put them into practice. So these are some online resources on mindfulness, self-compassion, happiness. There's an Action for Happiness organization in the UK, and some therapy and self-management tools. And finally, I would like to acknowledge my collaborators for the studies that from my own group, which I reported at the National Hospital for Neurology, or up in Newcastle. And the studies that from my own group were funded by the Medical Research Council. So I leave you with that, and thank you for listening, and I'm happy to take questions.
Many thanks, Marjan. That was so inspiring, and we have many questions, so I will start and I will try to concentrate by topic. So we start with one question that is, if I have anxiety or depression, can I deal with myself? For example, watching such presentation or reading books, or is specialist assistance necessary? You partially addressed that, but maybe you want to make another point on this question.
Always approaching your problems from a self-management perspective is useful. So yes, there are many things that you can do to help yourself with depression and anxiety. But I would have one reservation here by recommending self-management alone. If your depression and anxiety is extremely severe, you may also need to consult someone, either your neurologist or your GP or a psychiatrist, to get some medication to treat the depression and anxiety. So sometimes in the first instance, if the depression or the anxiety is very severe, having that type of help makes it easier for you to be able to then use these self-management strategies. So I would say yes, by all means. There are many resources available on the internet. There are many self-help books, recently written. Things based on sort of cognitive behavior therapy or positive psychology are usually evidence-based, and they will help. But it's a matter of gauging the severity of your depression or anxiety. So if your depression or anxiety is very severe, and your neurologist or your GP may be able to help you evaluate the extent of its severity, and then you may also need some form of medical management.
Okay, thanks. And then we have a very important question from Claire that asks, sometimes she feels angry towards herself because she's not able to control her dystonic movements, and that makes dystonia even worse. So any advice on how to manage this feeling of being angry at yourself? So she pointed out, I'm not angry to anybody else, I'm just angry to myself.
Yes, yeah. I can understand and appreciate her sense of anger, but there is some research suggesting that movement disorders like dystonia, as well as Parkinson's disease, are actually made worse by any form of emotional change. So getting angry at yourself and getting upset at yourself for being unable to control your dystonia is likely to actually feed into your dystonia and make it worse. So you should try to adopt the opposite strategy, is to relax. Any form of relaxation improves the dystonia. So letting go, letting your muscles relax, and relaxation techniques, biofeedback techniques, some even acupuncture relaxation have been used for treatment of dystonia. So while I appreciate that you may get angry, your anger doesn't serve you well. Try to get rid of the anger, try to get rid of the self-critical aspect, and try to focus on strategies that would help you improve your dystonia, like relaxation techniques. That would be my advice. And also this ability to switch off the self-critical mind. Sometimes we're our own worst enemies, trying to not to be so hard on yourself. You know, it's the dystonia is not your fault. You didn't bring this illness on. You have nothing to blame yourself for. And this self-critical, this anger towards yourself doesn't help matters. Let go of it. Let go of the anger. Show yourself some self-compassion. Think to yourself, what would you advise to a friend who was in your situation? What would you say to a friend who was feeling like you are feeling? You would probably be saying, be kinder to yourself, be gentler with yourself. Don't be so self-critical, would be my advice.
Thank you, Marjan. And now we have a question that is not related to anxiety and depression, but you mentioned about those emotional triggers for dystonia. So we have a couple of questions about other triggers for dystonia. For example, there was this woman that had dystonia in her arm and shoulder for 10 years, and she's wondering why every time that she's moving the arm, dystonia worsen. Is that a feature of dystonia to worsen with the movement because she cannot do anything?
I'm not quite sure that I think, I mean, there are, you probably notice better than I do. Aren't there sort of paroxysmal types of dystonia that are exercise related, etc.? So you probably can answer this question better than I can.
Yeah, but I can answer. So basically, Marjan very well illustrate how emotion, anxiety, depression, anger can worsen dystonia. But dystonia, by definition, is a movement disorder that is enhanced by movement, is action-induced. So typically, you might see a patient at rest not having much dystonia, but upon moving, dystonia increase. And this is very disabling, because if dystonia is localized to your arm, all the manual activities are disturbed. And related to that, there was somebody asking, is possible that hot weather improves dystonia? And I can surely, there is no science on that, but I can surely answer that because I used to work in Sicily, that is very hot during the summer. And typically, all my patients with cervical dystonia, they went back to me saying, you know, my dystonia has improved with the hot weather, and they needed even less botulinum toxin. It's a very interesting property that has never been studied, but I can say that that happened. I don't know, Marjan, if you know what you know, because in UK, obviously, I haven't noticed that. Yeah. Except now that for the reason to not climate change.
No, it's interesting because with these ideas about sensory aspects of dystonia, perhaps the warmth, the warmth, the temperature is probably altering sensory input into dystonia to some extent, and altering the dystonia. So maybe there is some scientific basis for it, but we don't know yet because nobody has examined this relationship, as you said.
Yeah, it's interesting. Marjan, another very important comment from Jill. I try to remain positive, but others' negativity can bring me down. How do I cope with those people? Currently, I avoid them.
The avoidance may be a good strategy. Yeah, this is a problem that some people actually describe. It's a sort of almost like a problem of emotional contagion, that, you know, you positive, but all the negativity around you is almost overshadowing or influencing or negating all your positivity. Now, in situations like this, avoidance is one strategy. Of course, the people you're avoiding depends what your relationship to them is. You know, if your partner is negative, you can't avoid your partner all the time. Or if it's your mother or your somebody who close, primary relative who's being negative, you can't, avoidance won't work as a strategy. And the alternative is maybe having a discussion with them and saying that, telling them that their negativity isn't helping you. If anything, it's actually hindering you. So instead of pushing it under the carpet and disregarding, discarding the negativity, bringing it up, discussing it, and saying to the person who's being negative that your negativity is not helping me. If anything, it's making me feel worse. So let's work together. Let's be positive. I'm trying to be positive, and I'm the most invested, the most affected individual in these circumstances. So help me in this respect rather than hinder me. So having it out with the person and bringing them on board so that they join you in positivity.
Thank you. Then we have one question from one of the youngest participants to this webinar. Is a person with dystonia, 26 years old, that would like to know if you notice in your experience that depression and anxiety affect differently younger individuals with dystonia, is generalized dystonia, opposed to like older individuals. Do you see that there is an age effect?
Yeah. Unfortunately, this was one of the questions I wanted to ask. I thought it was very important to address in research studies, the age effect, because getting dystonia at a younger age is very different from having adult onset dystonia at an older age. There must be some evidence on it, and I'm not, my answer is not necessarily based on this evidence because it's not in my head at the moment. But on the one hand, getting dystonia at a younger age allows people to adjust their self-esteem and their way of life and their to the dystonia, and to, in a sense, incorporate the dystonia in their being. So at one level, it may be easier for people who get dystonia at a younger age to adjust to it. On the other hand, if you're an older person, you've developed your self-esteem, you've developed your body concept, your body image, are all fairly developed, and then you develop dystonia, there is a disruption of your self-esteem and your body image, and you have to shift things to incorporate dystonia in your self-esteem, and this may require change. So it may be more difficult for older people, but as I said, this is an issue that was, I thought, is an important issue, a question to address. I know that in Parkinson's disease, for example, where a percentage of people with Parkinson's disease develop the disorder, although it's a disorder of old age, a proportion of patients develop Parkinson's disease before the age of 40 or 50. And we've studied this group of young onset Parkinson's disease, and their needs and their problems are slightly different from your standard elderly Parkinson's disease. So this comparison of patients with young onset disease dystonia and old onset dystonia is a very important issue. And as I said, I don't have the research evidence, if there is some out there in my head, but it's an important question to address in research.
Yeah, I totally agree, and I think your interpretation is very much correct, because is the feeling also in clinic, but it's really an important question that needs to be answered, because identifying people that is at risk, it's important now to concentrate on that population. And Danik, that she's 26-year-old with dystonia, has concern on how different is dystonia, even in terms of physical manifestation, because it's generalized dystonia. Younger individual dystonia tends to be more generalized, whereas in older individual tends to be focal or segmental, meaning like one or two body district affected. But like the strategy, I have seen amazing strategy of coping in a young individual with dystonia that really keep on living, and like they keep on working, so they are not unemployed. They really have their successful life. I think that you have seen the same as well. So another very important question from Marite, our friend Marite, that she heard that there are some medication for anxiety and depression that can worsen dystonia and should be avoided if you have dystonia. Is this correct? And at this regard, it's important that neurologist is a part of that, making the choice for medication for anxiety, depression, or discussing with the neuropsychiatrist, because otherwise people with dystonia might be given the wrong medication that worsens dystonia. So can you tell us something about that?
Yes. Yeah, there are mainly single case reports that certain types of antidepressants medication for treatment of depression, particularly SSRIs, the serotonin reuptake inhibitors, can worsen symptoms of dystonia. But as far as I know, you may know better, Francesca, there haven't really been many randomized controlled trials to decide what's the best medical treatment for depression or for anxiety in dystonia. And it's about time somebody took these non-motor symptoms of dystonia seriously and tried out and compared different types of antidepressants. From the literature that I have read, it basically suggests, yes, some types of some types of antidepressant medication can make symptoms of dystonia worse. So switch the type of antidepressant, try another one, maybe monoamine oxidase inhibitor type or a tricyclic antidepressant, and they may work better in treating the depression and not having a negative influence on the symptoms of dystonia. In terms of treatment of anxiety, the benzodiazepines, the anxiolytics that are used for treatment of anxiety are usually sometimes also used for treating dystonia. Then they can sort of help some of the involuntary movements of dystonia. So I don't really know of any anti-anxiety medication that have made dystonia worse. I don't know whether you're aware of any.
So the thing you said very correctly, because it's just time to do a serious randomized control trial to understand which medication to use for depression and anxiety in dystonia. It's all very anecdotic. I've been using tricyclic antidepressant because they are very good also for pain, and also they may help with tremor for cervical dystonia. So using this, effect, I've been using, but without, there is no evidence based on that. And so what is very important to highlight is that I have been seeing that in Italy. I had to tell you that in Italy psychiatrists use sometimes antipsychotic medication to treat dystonic patient for several, especially at onset, because dystonia was misdiagnosed, and that worsened dystonia very much. So it's very important that especially when they arrive to the neurologist's attention, they arrive with the list of the medication, but also the history of medication, because reviewing that for the neurologist is fundamental. And I have found 20-30% of cases antipsychotic medications there that can worsen. But it changed. I think
that can actually worsen. Yeah, and result in tardive dystonia. But yeah, as you said, I think in this case, just relying on maybe GPs prescribing for anxiety and depression may be problematic, because at least neurologists, movement disorder specialists, neurologists, are aware of the pitfalls of what they're prescribing.
Yeah, that's a very important take-home message. So there are a lot of compliments from everybody, people that would like to have access to the 23 commandments. And Adam said that this webinar has been recorded, so will be available, so everybody could look to your 23 commandments and also advice for managing anxiety and depression in COVID pandemic. And Jill, that also would like to remember the late Dr. Butler that she knew, said that she find keeping busy really helped us. It distracts my mind and also distract my dystonia. So if she's busy, dystonia subside. Is this common? Being engaged like in some other activity that improve dystonia can be a strategy that you would suggest to cope with dystonia.
Yes. Attention is an important thing, and distraction, of course, is a form of taking your attention away from your dystonia and focusing on something else. And attending too much on anything can be problematic. So, for example, when you're ill, if you're constantly focusing on your illness and monitoring yourself for symptoms, you only feel worse. Keep taking your attention away from the illness and relaxing usually provides you with some respite. There is some work on, again, I don't think that there has been much on attention and symptoms on dystonia, but there have been things on maybe Parkinson's disease, suggesting that attentional focusing can either be a good thing or a bad thing depending on what you're doing. So, for example, with Parkinson's disease, walking, which is normally automatic and happens without attention, is being done in a very focused and step-by-step fashion. And teaching patients to take away the attention from their walking and let it run automatically may actually help them achieve better walking. So attention and movement disorders is, again, an interesting area for research and investigation. And I think it's one of those areas that hasn't really been touched in dystonia.
No, I don't. I mean, like, it's every time we do this meeting and we speak to people that have dystonia, we learn new things, because really there are many gaps, many mysteries that we really need to address.
Yes.
And it's important because we know their need. You know, Marjan, I really want to thank you, because I was very touched by your advice of kindness, especially in this world. And I really believe this is a key for everybody that has a chronic disease. And I just want to make a comment. It's something that I always say to people that have chronic disease. I follow people with dystonia. I follow people with young onset Parkinson. And I always suggest them to be kind, engaging themselves in the patient association. So doing something for people that have their condition. And actually I found out that being busy, like working for a patient association, can be Dystonia Europe, can be Parkinson UK, whatever this, patient association, really made their life better and even coping, because they felt that their condition helped us to help others. I don't know which is your experience with that. That is my personal comment.
Yeah, I mean, there's a lot of research suggesting that kindness, there is a sort of saying, do good to feel good. So doing any form of good for other people makes the person who does the goodness or the kindness also feel well. There's that element. And there's also the element of being appreciated, feeling valued, feeling that what you're doing, your efforts are being appreciated by others. Those are things that really help people address a different dimension of their illness. They consider things, the new avenues that have been opened up for them to engage in, as opposed to just thinking about all the negative impact of the illness on their lives. Yeah, so I think kindness, doing good, takes you out of yourself and considers the well-being of others, and in a sense, in a sort of a cyclic fashion, helps you feel better as well.
So we keep on having a lot of questions, a very challenging one, but really inspiring. Another one is that, Marjan, are there any study on the impact of hormonal disorders in women, a worsening of dystonia? My question is related to the worsening of symptoms of cervical dystonia before menstruation and also low mood in the same period. Very difficult question.
We did with Neil Quinn some years ago. We did, Neil Quinn was a consultant at the professor of neurology at the Institute of Neurology. We looked at these issues in Parkinson's disease in a paper that's unfortunately not published yet. So there are, again, studies on this, the menstrual cycle, menopause, etc., these female milestones, and severity, defects, and pregnancy, for people who are younger. They have been examined for Parkinson's disease. As far as I know, none of these issues have actually been looked at in dystonia. And again, another challenge for people like you to take up, Francesca.
No, yeah, it's actually, this is common because first of all, we shouldn't forget that cervical dystonia is more frequent in women. So there is a gender effect, and so it should be an hormonal effect. The second thing, I've been listening to this story many times. So my symptoms are worse, and the same for young onset Parkinson that have dystonia. So I follow up few young onset Parkinson. They have a mutation that is called Parkin, and they have dystonia as a manifestation in their legs. And their dystonia worsened during menstruation, just before. So they always say, okay, when they contact me, now they know, they pointed out, it's close to my period. And so it's not been studied. And I mean, like, it's really, when we talk about patient public engagement, is that we really should, my lesson from COVID is we really need to talk more frequently to patients, because otherwise we are just using our time in searching things that are not needed. And these are needs. These are really things that matter. So definitely, there might be an involvement, but we don't have any data. And if there are no data in research, we cannot say that something is true, and we cannot even, develop strategies. So we have to write on the to-do list, and we have to do that.
Yes. I've actually just written 3 things that I think
I'm taking
conversations require further research.
I'm taking notes. So can you explain what is obsessive compulsive disorder that you mentioned, but maybe it didn't come through exactly what is a obsessive compulsive, so how a person can recognize to have obsessive compulsive disorder symptoms?
Obsessive compulsive disorder, the obsessional part of it is people having repetitive thoughts, which are called ruminations or obsessions. So repetitive thoughts of either danger to endangering themselves or danger to others, or they may be ritualistic things like numbers that they count in their heads before they do something. So obsessions differ. Compulsions are repetitive behaviors that are done, and both obsessions and compulsions are engaged in to relieve the anxiety that people feel. That these thoughts and their behaviors are engaged in to relieve the anxiety. And for example, somebody who's a washer, to relieve the anxiety of contamination, the belief that their hands have become dirty or contaminated, may wash their hands up to, I don't know, 200 times a day. Or somebody who's a checker may, every time they want to leave the house, they have a pattern of checking, like they may have to check every single window, they may have to check every single door, they may have to check the gas, the cooker, etc., before they leave the house. There's also another element of it called primary obsessional slowness. People who are so obsessively slow, and so their behavior is so ritualistic. So, for example, to take a shower or a bath would take 3 or 4 hours. So these obsessions and compulsions take up so much time in the day that people sometimes have to give up work as a result, and it has a negative impact on the quality of life of people. Now, obsessive compulsive disorders are relatively rare in the general population, about 1% according to the World Health Organization. So the rates in dystonia are relatively high, and the studies that have examined it have found an association between obsessive compulsive disorder and dystonia. Now, there's a lot of evidence from people who've got primary obsessive compulsive disorder, so people who have this disorder on its own, that the basal ganglia, the part of the brain that goes wrong in dystonia as well, is also involved in obsessive compulsive disorder. So maybe this overlap in the basal ganglia is something that gives the association with both dystonia as well as with Parkinson's disease.
And Marjan, you mentioned the basal ganglia, and I want to ask you a question that we had by email from Finland. And this person, that was James, asked us which part of the basal ganglia goes wrong in dystonia.
The basal ganglia are considered to be affected in basal ganglia according to models of hyperactivity disorders like dystonia. According to the models like the DeLong model, there is apparently let me try to think. In Parkinson's disease, there's too much inhibitory outflow from the basal ganglia, which results in things like slowness, etc. In dystonia, on the other hand, there is too little inhibition from the basal ganglia to the cortex, and as a result, you get the dystonic movements and the dystonic postures and the muscle cramps. So that's the model, the DeLong and the Albin models of basal ganglia disorder. Now, there is increasing evidence from imaging that the cerebellum, a part of the brain that is based at the base of the brain, may also be involved in dystonia. So dystonia may not be a pure basal ganglia disorder, but other systems of the brain may also be involved, such as the cerebellum.
Thank you. And another question is from Miriam. Miriam has a spasmodic dysphonia, so laryngeal dystonia. And she was wondering how come that she's injected always with the same dose in the same muscle, but sometimes she have a brilliant effect for 3 months and a half, and sometimes she does not have any effect at all. Is in that emotional control is involved, or like is a feature of botulinum toxin? What may cause this, fluctuation, unpredictable, that is unpredictable response to botulinum toxin?
If I remember correctly, aren't there some reports of developing habituation or tolerance to botulinum toxin injections. It's possible that, but perhaps the site of injection is slightly different in the ones where she's seeing an effect versus the times when it doesn't work as much. All I can think of is the exact target, and the dosage. So dosage and the target are important. And you're probably more experienced in actually doing this than I am in giving botulinum toxin injections.
This is an important question because I had this question for all types of dystonia. I think that sometimes when we go very deep inside, emotional factors are very much involved. For example, in cervical dystonia, if a person underwent a very stressful period, so that determine a suboptimal response. Obviously, there are also causes determined by the injection site, because botulinum toxin, to be very, very much effective, should be injected in the motor point, that is basically a point of the muscle that is next to the a part of the muscle is called end plate, and this is unpredictable. So you may have that amazing effect, and sometimes you have the suboptimal effect. For spasmodic dysphonia, I think is more a technical approach, but again, it's never been studied. I could see that really sometimes, even regardless of what you do, despite you have injected the right dose, there is no resistance. Some injection fails, and that might be due to what this person is going through. Maybe it's due to we don't know, like the temperature today was raised, that the temperature was a factor.
Yes.
So we really don't know. And this is a very important question. As far as as we know, there are no still reports on the effect on COVID-19 on dystonia. So nothing has been published as far as I know. I don't know if you have been aware of that, but I tracked, and there is nothing published.
No, I've seen a couple of things on Parkinson's disease and COVID, but I haven't seen anything on dystonia and COVID-19. Maybe undoubtedly there will be some publications on it in the future.
Yeah, nothing has been published yet. We know from Parkinson's disease research, a big Italian study on more than 1,000 patients, that Parkinson's patients do not have a higher risk of COVID, and also their susceptibility to develop severe complication is not higher compared to general population. So this is a very frail population, and maybe we might hope that we can extend this finding. Thankfully, none of my patients, as far as I know, had COVID or had severe complication from COVID, because otherwise we would have known. So we are looking for this data to make people more comfortable, even like the next month coming. And I think that we have answered most of the question. Another question that maybe I can answer is more like clinical question is from Miriam, that she's have pain to the ear and she has spasmodic dystonia. But when Botox ends, she struggles a lot with the pain in the ear. So these are mysterious. It's such a bizarre condition, dystonia. I've been seeing that injecting in a site of the body, a contiguous site where there is some dystonic movement, can improve even without being injected. It's like changing the sensory component of dystonia, because we might change the sensory component, not just the muscle, just change the organization of the brain networks and then affect other dystonic muscle. I don't know, again, this phenomenon has not been studied very well. I don't know if you've seen that, Marjan. Even cervical dystonia, I think it's common that you inject a group of muscle, but then other muscle improve as well. Yeah.
Yes. Well, remember that the toxin injection may have distant effects.
Yeah.
So it's not necessarily localized.
Yeah. Yeah, in the good and the bad, because sometimes we can have side effects because of this distant effect. So I think that we have answered everything. Lots of compliments to Marjan from all people connected. Thank you so much for this great webinar, very inspirational, great information. And I will pass on to you, Marjan, to say hi to all the friends of Dystonia Europe. And I want to thank again Monica and Adam.
Yeah, equally, I would like to thank you, Francesca, for moderating the questions, and to Monica and Adam for organizing this and being so organized with everything as usual. It's always a delight to join you.
Thank you. Monica, do you want to
Thank
say
you.
something?
Thank you very much, both Marjan and Francesca. And it was, like I said before, always when I listen to you, Marjan, and listening to all the questions and the answers, it gives me so much new information and input on how to live with my dystonia and how to move forward. And I would like to say a few things, just to say that it is summer now. We can be grateful for summer. We can look forward maybe to warm weather where we can relax our muscles and we can see our friends and family and we can laugh a lot. Thank you.
Yeah, thank you.
Good strategies.
Very good.
Yeah. And I want to say that today, before I go sleep, I can add to my list that I'm really grateful of having such a dedicated and charismatic and experienced specialist on the boat, that we can have opportunity to have such a meeting with you, because that it's wonderful. And yeah, I want to say also to attendees that we have heard lots of things today, and we learned a lot. And it was difficult maybe to remember everything. So that meeting was recorded and will be available on our Dystonia Europe YouTube channel. Yeah, so I want to thank our panelists. I want to thanks to our attendees for joining and for interacting. And also we had a few attendees on the Facebook, so thank you also for that. And I wish you, all of you, a nice weekend and lots of social interacting.
Thank you very much.
All right.
Thank you.